Hello everyone, I am Fernando Rojas Vizcaya, I am oral surgeon and I am a prosthodontist. My presentation for today is about a rule that I name the 3A to B rule. But the reality is that this rule is just part of a comprehensive treatment planning. But we don't have enough time to present all this treatment plan. So I want to focus in this 3A2P rule because I think it's a very important aspect and we can apply in our different treatment plan that we are doing with our patient. But I want to make an overview to set all this information in this frame of this comprehensive implant therapy. Basically, what we are doing when we are working with dental implant is determine as a first point the position of the new prosthetic teeth for our patient in relation with the face of the patient in the 3D position to give the ideal lip support, to obtain the ideal smile line. Once we have the ideal position of the prosthetic teeth, we will go and check where is the position of the bone in relation with this teeth to determine the type of treatment. But we need to incorporate many components, extraoral and intraoral. Always in all type of treatment we can give to our patient function and aesthetic with different type of restoration. Like this case, maybe it's with a complete denture or with over denture, maybe it's a fixed detachable in different material, maybe it's a fixed restoration. So we need to take into consideration some point to make our analysis. And the 3A to B rule is just part of this full set of points. Points that remain stable in the face of the patient, extraoral and intraoral. We have some extraoral information, vertical and horizontal lines that we can use as reference. Using these extraoral lines together with the intraoral information, we will be able to determine the 3D position of the teeth. Once we know where is the position of the new teeth for our patient, using the margin of the plant crown of this new restoration, we will make the analysis between this crown and the existing bone. And it's here where we will apply the 3A to B rule as a diagnostic tool. And we will use also to place the implant. After we can make this analysis between the crown and the existing bone, we will be able to determine the type of restoration. And for every of these step of this key point of reference, we have names and we can use more. This is just the basic that I am using to do my analysis. So in the extraoral information I have the midline, the horizontal line, very important, the length of the lips and how the lips are working in relation with the teeth. We have some intraoral information, intraoral key point of reference to use during our analysis. So we have the incisive papilla. I always use the distal portion because it remains stable. Very important, we have the mucolabial reflection in the maxilla and in the mandible. And also one point that is very important and always as a prosthodontist we can use, that is the retromolar pad. This point remains stable, so we can use as reference. Using this extraoral and this intraoral information, we will determine some points in the new prosthesis, in the new teeth of the patient. We will determine what is the incisal edge if we are talking about a fully maxillary rehabilitation. What is the incisal edge of the patient, of the maxillary central incisor, in relation with the upper lip? What is the midline? What is the tip of the canines? We will determine the occlusal plane, and after that, where is the margin of this new crown. So once you know where is the new teeth, because you made your wax up, or maybe using a base plate, you set a denture teeth, different ways. But once you know what is the new teeth position, you can go and make the analysis between the margin of the planned crown in relation with the existing bone. And we will see in apical direction and in a lingual direction where is this bone. Once you make this analysis, you will see that maybe your patient is for overdenture, maybe it's for fixed detachable, maybe it's for fixed. So as I told you at the beginning, this sequence we will use in a edentulous patient or in patient with terminal dentition, where we cannot use any of these points that the existing teeth show, because maybe this is not the perfect incisal edge position, maybe this is not the tip of the canine. So we need to use points that remain stable. But to explain the 3A to B rule, I just want to focus in the restoration of a single tooth, like this molar. So if we are planning to restore a molar, you need to think about if is a fully maxilla. We will apply the same concept. Here, the first step is to determine the position of the new crown, with or without bone. We need to restore the ideal crown here. Once we have the new crown, the perfect crown, we will check where is the bone in relation with this crown. So, from the prosthesis that we are planning here, we only need where is the occlusal plane and where is the margin of this new molar, right? We don't need some extraoral information or intraoral information, just with these two aspects. And the first one is where is the occlusal plane, because it's only one. And after, where is the margin? Once you know what is the margin, your next step is where is the position of the bone. But we need to fix the occlusal plane, and we cannot move this occlusal plane. After that, we fix the margin or the cervical contour of the crown, and you cannot move during your analysis. And after that, make the analysis in relation with the bone. Right? So our first step is here. What is the occlusal plane? Here is very simple. I want to show you this case because it's very simple, and I want to compare it with the next one to explain why it's very important this 3A to B rule. So once you determine what is the occlusal plane, that here is easy because you have opposite dentition, you have adjacent teeth in a correct position. Now you determine what is the gingival contour or what is the margin of the planned crown. Also here is very simple because you have adjacent teeth, and give by symmetry what is the ideal position. So at this point you have your crown, right? You can make a wax up or you can use a denture tooth just to show to your patient what is the idea of the treatment. But here you have occlusal plane and margin of the crown, like in a fully maxilla. Imagine that you are doing a fully maxilla in a patient that is edentulous for 20 years. First step is also determine what is the incisal edge and the occlusal plane. Next one, what is the margin of the crown? And the next one, where is the bone? Is the bone in a perfect position? And what is the perfect position of the bone? Here is when I want to present the 3A2B rule. That is basically a mix of concepts, but I want to make easy to work with. What is this 3A2B rule? I also published this 3A2B rule in the Journal of Prosthodontics at the beginning of this year, so you can obtain the same information in detail in this paper. The rules say, once you fix your crown in your treatment plan analysis, now you cannot move the occlusal plane, you cannot move the margin of this crown. The 3A2B rule says that you need to place an implant from the margin of the crown that you design in the apical direction at 3 mm. But why we need to place this implant from the margin at 3 mm? Because this is in average. The dimension of the biologic width could be less or more, but this is average. So this is why I work with this number. This is the 3A part of the rule. Now, we also speak about placing the implant guided from prosthetic point of view, and we want to place the implant from the margin of the plant crown in a lingual direction 2 mm. At why 2 mm? Basically because we want to keep 2 mm of buccal bone. If we have less, we can lose this bone. Could be around 1.8. So this is why I call the rule 3A to B, because the implant need to be from the margin 3 mm apical, and after you place the implant you need to keep 2 mm of buccal bone, 3A to B. But if you check this slide, the only way to place the implant in relation with this crown and obtain 3A to B, like I show you, is if we have enough bone and in the perfect position, like this situation. Can you see that the bone is at 3 mm from the margin and you have enough bone in a lingual direction to be able to keep 2B. So we can place the implant at the level of the bone, and it's 3A, and in a lingual direction until you be able to preserve this 2B. So our first step is determine the occlusal plane and the margin of the crown and follow the sequence. After that, and make the analysis between the margin of the crown and the position of the bone. And in this particular case, bone was at 3 mm. So when I open this flap, I start looking for the 3A to B rule. I know that by placing the implant at the level of the bone, I will obtain the 3A. You can see that bone is at 3 mm from the margin. And in lingual direction, if I measure from the margin in a lingual direction 2 mm, I have enough bone to place the implant in this position and make sure that I will have the 2B part of the rule. So now just make the osteotomy and here I have my implant in position. And I apply here the 3A to B rule, but this is a very simple case because the bone is in a perfect position and we have enough bone. Now you can see implant at the level of the bone is 3A, and by drilling carefully I can make sure that I finish with 2B. Also I can apply the 3A to B rule in implant with different platforms like the profile implant. You can see that also it's possible to place the implant and follow the 3A to B rule. Remember that the space for the pink and for the white aesthetic is determined by placing the implant in the correct depth. What is the correct depth? From the margin of the planted crown in apical direction, 3 mm. Once I place the implant, case is done because I fix this space. Can you see? This is the space for pink aesthetic. And now using this CAD-CAM abutment, that is the Atlantis Gold Hue abutment, I will provide the support for the pink aesthetic that I create by placing the implant deep enough. And also this abutment will support the crown for the white aesthetic that I planned. You can see the abutment in position, and here you can see all the space for the pink and white aesthetic is determined and fixed when I place the implant in the correct depth from the margin of a planted crown. If you are doing a full mouth reconstruction using dental implants, for every crown where you are planning to place your implant, you will make this analysis, and maybe for every implant bone is at 3 mm, or maybe it's more, and it's an indication for a different type of restoration, or maybe it's less. So you can see here that after screw the abutment, you have the space for pink aesthetic and the space for white aesthetic. So if you use the 3A to B rule, you can enhance the predictability of your case. Now, because implant and abutment are working together, can help in the preservation of the marginal bone, and we will preserve the aesthetic that we create for our patient. We can do the same in a full mouth reconstruction. And the easy case could be when you make the analysis and the distance between the margin to the bone always is 3 mm, and you have enough bone to keep 2B. This could be the simple case. Now let me show you different case to explain some important aspect that we need to take into consideration, and it's something that always we can see in our office. We need to restore this maxillary lateral incisor with a dental implant. We will follow the same process. First step, where is the incisal edge, the occlusal plane. Here we only need to determine where is the incisal edge. You fix this incisal edge where you think that is correctly aesthetically for the patient. The second step is determine what is the margin of the crown or the cervical contour. You are looking here for the balance of the gingival level, so you want this margin of the crown a little bit below the line that runs from the central to canine, around 1 mm. So you fix this margin of your crown. Remember, you cannot move the incisal edge, you cannot move the margin of the crown. You can show to your patient, and this could be a fully maxillary rehabilitation. You are doing the same analysis. Once you fix this crown in your analysis, you can show to your patient what is the next step. The next step is make the analysis between the margin of this crown and the existing bone. So let's go and make the analysis like we make in the molar. So we fabricate our thermoplastic template, we apply any radiopaque material that can show us where is the margin of this crown. Can you see? And send the patient for the tomogram. But before, let me show you the ruler that I use to make this analysis. It's a radiographic biological ruler where I can apply the 3A tube rule, and I also add some extra information that always we need to use to determine all these remaining stable points of reference to do all the analysis. And you can see also the rule in the Journal of Prosthodontics that I published with the 3A tube rule. And this 3A tube rule is based in the information about the average dimension of biologic width in dental implant and the minimum buccal bone that we need to preserve to avoid its resorption. This is 3A to B. Now let me show you this portion of the rule. That is the portion of the rule that we can use to make the analysis. Here you have the 3 mm space, can you see? And also you have the 2 mm of a buccal bone space that you need. So once you set the rule in your tomogram, this needs to be the position of the implant, where you can see you will have 2 mm in one side and you will have the 3 mm for the biologic width. And you can see also what is the prosthetic zone in cases that you are working with the screw retainer restoration and maybe you need the access for palatal or for occlusal. Now let me show you how we can use in the real case. So you have your crown. Remember that we fix this crown. The incisal edge is perfect for the patient and the margin of the crown is perfect for the patient, so we cannot move. Now we need to do the analysis. Let me show you where is the bone. Now this is the point of reference, the margin of the crown, to make the analysis. So the rule, you can see this is 3 mm in the area of biologic width, so I can rotate the rule until it's in the correct position. Now you have in the space of 3A, you have bone. Can you see the difference with the molar? The bone is not at 3 mm. The bone is in contact with the margin. But we know that in average, the biologic width need to be 3 mm. And when you make the analysis of the 2B, you can see that you have enough bone to maintain the 2B. So, by doing the analysis, I will determine that 3A need to be here. I need my implant 3 mm apical from the margin. So I need to reduce this bone if I want my implant at 3 mm. And later, I need to place the implant in a palatal direction enough to create this 2B. So this needs to be the position of my implant. And I can apply here, you can see the 3A to B rule. If I can place the implant here, I will obtain the space for biologic width where I can screw here an abutment, create the ideal profile for this crown, subgingival portion of this crown, and I expect to obtain this situation with this length of clinical crown. So now let's go and place the implant. Where? From the margin at 3 mm. Now I know that I have too much bone. It's not like the molar. So I start using my burr and reducing the bone. Now I have around 1.5. and I reduce a little bit more bone until I can evaluate that I have 3A. Now this situation is like the molar that I showed you at the beginning. Now I have 3A. So now I can place the implant at the level of this new bone position. So now I start looking for the 2B part of the rule. Now I have the 3A. Now the implant could be at the level because I create the 3A. And drilling in a correct position in a palatal direction, at the end I can obtain the 2B part of the rule. So I can place the implant deep enough from the margin of the plant crown. When I place the implant at the level of the bone and maintain 2 mm buccal bone, I will preserve this bone and I will be able to obtain the length of the clinical crown that I plan. Now my implant is 3A2B. And you see, I can screw the healing abutment, or maybe I can do the immediate provisionalization. For any way, I have the space for pink and white aesthetic according with my plan. I decide to do a conventional loading here. Can you see where is the position of the implant? But let me show you the difference between place the implant just surgical guided, that means just where is the bone, or place the implant prosthetically guided, that means using the prosthesis as reference to place the implant. In both cases, at the end, I will have the same incisal edge, right? I only have one position. But you can see here, I place the implant in one side according with the margin of the crown that I designed, 3A. And in the process to place the implant 3A or 3 mm apical, I need to reduce bone here. But in the other side, I don't use any template. I just place the implant where I have bone. That this is a case that I can see many times. Place the implant just where is the bone. Now take a look. In both cases, you need to connect an abutment, right? To make a crown. Now you can see that one of the crown is very short. And if it is after the osseointegration, and when you trade in the crown is very short, how you can make the margin of the crown go in the apical direction? Maybe by adding ceramic and overlap. This could be an aesthetic solution, but the patient cannot clean below this area, and we can lose this implant after years. So this is the situation that we want to avoid. And this is why it's very important planning the case from the prosthetic point of view, because at the end of the case we will cement it or screw one restoration or a fully maxilla, and we need to plan for the ideal length of the crown with the ideal emergence profile. So we stay in this situation, and this is after healing. We don't have any pink aesthetic here, but we have the space for pink and white aesthetic, because we know that we place the implant 3A to B. Can you see? You have a circular emergence profile, but remember that you have 2 mm of buccal bone. So I can make my final impression, and now in the master cast, when I remove the soft tissue, I can verify that the implant is from the margin at 3 mm. I connect my abutment, and in this subgingival portion I can create the ideal emergence profile for the crown, and I can modify this soft tissue here. And you see, I can use any bar from the lab and start reducing and creating the ideal contour of the soft tissue. And now I have the design of the soft tissue according with the crown that I'm planning for the patient. And you see, the margin of the crown now is the same level of the soft tissue. And I can fabricate my provisional restoration that we expect that compress the soft tissue and transform or guide the soft tissue to the new shape. Now, this is the day that I want to screw my prosthesis. So I make light compression, the patient can bite for a few minutes. You can see here the soft tissue, color because the ischemia. Now this is after a few minutes. You can see the black triangle in the distal area, and this is after a few days. Now the margin of the crown is according with the design that you make for your crown. So we can make by CAD/CAM our abutment to fill this space, and in this particular case I like to, in this type of cases, cement extraorally this crown into the abutment so I can screw the prosthesis. In case that I have some problems, I can remove very easily. So we fabricate a CAD/CAM abutment. This is an Atlantis Gold Hue abutment from Dentsply, and I fabricate a lateral incisor made of monolithic zirconia restoration. This is the Pretau from Zirconsan. And I make the extraoral cementation. I just screw the abutment in position, cover the axis of the screw with a cotton or with any material. Now cement the crown. I apply the material for cementation to make compression of the crown, and now remove the excess of the cement, and you clean perfectly. Now you can remove the excess of the cement and the cotton from the area that you blocked before, and now you have a restoration ready to screw into the implant. Now I remove the provisional restoration, and this is the final restoration. You can see where is the level of the bone. It's at the level of the implant, and you have mesial and distal space for the interproximal papilla, and you have the margin of your plant crown at the level that you planning before. Can you see that the lines that run from central to canine, the lateral is around 1 millimeter below? So this is the 3A to B rule. But let me show you a complex case from this pool of patients in this maxillary rehabilitation of immediate placement and immediate loading protocol. So I will skip all the process of make about how I can make the analysis using the extraoral information, intraoral information, how you mix this information, because this is topic for another presentation that I will make in few months here also in Dental XP. And now we are speaking just about the 3A to B rule. So this is one of the old cases that I have. Let me show you that in the analysis you can see here that we have a good space to place implant. I can tell you that sinus is far away and we have enough bone to place implant here. But when you make this lateral view in occlusion, can you see the sternal occlusal plane? This is probably because before lose the upper molar, you have the patient in this situation. So the dentist maybe restore the lower molar to be able to occlude. The patient later lose the upper molar, and also in the over eruption or extrusion of this molar, the bone can go down a little bit. And when we are speaking about aesthetic, 1 millimeter or 2 is a big difference. Imagine that you have one lateral 1 or 2 millimeter longer or shorter than the other side. You compromise the aesthetic. And in the other side, take a look what is the position of the occlusal plane. This is maybe because make the lower fixed restoration. Patient have some over extrusion because the absence of the lower teeth. Later the dentist make this fixed partial denture, but probably in the over extrusion process the bone go down a little bit, 1, 2, 3 millimeter, we don't know, but this bone go down a little bit. So we follow the same process just to make the analysis of the 3A tuber rule. We want to see if the bone is like the molar or maybe like the lateral that I showed you before. Once you make or determine the 3D position of your teeth, I skip all the process about how I can know that this is the position. Remember that this is the topic for a different presentation. I just want to explain what is the 3A to B rule and how we can apply in a simple or complex case. My first step here was to determine what is the incisal edge of the maxillary central incisor, what is the tip of the canine and the full occlusal plane. After that, what is the margin of the new crown? The maxillary central incisor is 10.5 millimeters, so you can see that it's a natural size proportion of this teeth. We have a good relationship between central, lateral, and canine and the posterior teeth. We send the patient for tomogram as we made with the molar or with the lateral that I showed you before. And I want to show you two slides. One where when you measure the distance between the margin to the bone, you have the 3A. This is like the molar that I showed you at the beginning. And this slide is for the maxillary left first molar of this patient. So here looks like I only need to place the implant at the level of the bone, but a little bit palatal to keep the 2B. And this is the slide of the canine of this patient that is similar, imagine, like the patient that I showed you before of the lateral. Can you see that to apply the 3A rule, I need to reduce bone? The bone is in contact with the margin of the crown, but remember that we cannot move the crown that we're planning because these crowns are okay for our patient. So first step, what is incisal edge, occlusal plane, margin of the crown. This is the existing soft tissue, the dot and red line, the existing soft tissue. And this is the level of the bone. I know that this is the position of the bone because I have the tomogram, like I made with the lateral or the molar that I showed you before. And I can measure the distance in the tomogram. And I can see that the bone in the central is 1.5 millimeters. The lateral is in contact with the bone. The canine also is in contact, the margin is in contact with the bone. For the first premolar, I have 1.5, but this is for oviponic. The second premolar is 2 millimeters, and the first molar is 3 millimeters. I want to place implant according with the protocol that I learned in central canine, first premolar and first molar, and oviponic in lateral and second premolar. And I want to fabricate 4 fixed partial dentures from central to canine and for first premolar to first molar. Now I need to know also the distance from the margin or from the cervical contour to the implant. I always want 3 millimeters, but I want to know also the distance from the cervical contour to the ovate pontic, because where I have ovate pontic, below I will have acrylic or ceramic later. So I need a space for the soft tissue, and I need a space for the material of the ovate pontic. So I need to make the analysis between the ovate pontic and the position of the bone, because I need to reduce space. Let me focus in this area. So we need the 3A part of the rule. We need to place implant from the margin at 3 millimeters from the cervical contour. You can see that in the molar I have 3 millimeter distance. This is like the molar that I showed you before. So here I can place my implant just at the level of the bone, but in palatal position, to make sure that I have at least 2B. So I can screw my abutment and create a perfect emergence profile. And I expect that the soft tissue heal around this area. Now, what about in the first premolar that we have the bone at 1.5 millimeters, and I want my implant at 3 millimeters. So I need to reduce the bone. This is like the lateral that I showed you before. Or in the canine area that is in contact with the bone. It's like the lateral also. If I want my implant at 3 millimeters, I need to reduce the bone also. Once I reduce the bone, I can place the implant at the level of the bone. This is like the lateral. And now I create the situation like the molar. Now, implant of canine and premolar are at 3 millimeters from the margin. Now I have the 3A part of the rule, and I need to make sure that I put the implant in a palatal direction until I can obtain the 2B part of the rule. I will have the space for the abutment to fabricate this emergence profile, control the distance between contact point to the level of the bone, to give the ideal space for the interproximal papilla. And what about the area of the ovate pontic? Depend of the depth of your ovate pontic. I always work with 1.5 millimeter ovate pontic, and I need below the ovate pontic at least 1.5 millimeter to give the space for the soft tissue. So I am planning to reduce also a little bit in this premolar. So I expect to reduce the bone in some areas, place the implant, connect the abutment, and when I cemented this prosthesis, I expect that the soft tissue heal around this abutment and this prosthesis, and I expect to guide the soft tissue during the healing process to the shape of this prosthesis. Now, let me show you what happened in the anterior area. For the ovate pontic of the lateral, I also need a space, so I am planning to reduce and create a space for the ovate pontic. But here is important. Take a look in the central, that I have a extraction socket area, and the bone at the beginning is at 1.5 millimeter distant from the margin. But I need my implant from the margin at 3 millimeter, because this is later the average dimension of the biologic width. If it's extraction socket area, I don't make any reduction of the bone. I just place the implant at 3 millimeters from the margin of the planet ground, and it's below the bone. And I keep the bone in this position because after we screw our abutment, we expect some bone remodelation in this area. between 1 to 1.5 millimeter. This is the reason because in the extraction socket area I will not make any bone reduction. So for this way is how I planning the cases. And let me show you the difference between place the implant, surgical guide or prosthetically guided. In the left side of the screen you can see what is the level of the bone. It's a flat area. And in the other side is after I make the bone modeling. My plan at the beginning was to place the implant from the margin 3A here to give the space later for biologic width. In this space I will localize the abutment. But imagine that you place the implant just surgical guide. This means that you place the implant in a correct mesiodistal buccolingual position, but you place the implant where is the bone, so at the level of the bone. Now you will connect anyway your abutment, right? The occlusal plane need to be the same in both cases, left and right. Now in your provisional you need to remove all this acrylic because you don't have space for the ovate pontic or the lateral, so you need to reduce the ovate pontic. You need to remove acrylic in the area of the canine and first premolar in order to fit this prosthesis. But now you are changing the shape of your prosthesis. And once you finish with the immediate loading protocol in the left side and you suture, anyway the soft tissue will heal around and you will obtain around 3 millimeter high of this soft tissue. But in the other side, where we follow the direction of the prosthesis and place the implant from the margin 3 millimeter apically, and I make the reduction like in the molar that I showed you at the beginning. So now you have the implant deep enough to create the space for pink and white aesthetic. You connect your abutment, and this is after you suture and after healing. You can see the difference. In both cases you place maybe the central in the same position, so in both cases you have the same clinical crown in both central. But now in one side you have a short lateral, short canine, short first premolar, and in the area where you place the implant guided for the prosthesis, you have the correct length of the lateral canine and premolar. And in both cases maybe you have the same molar, because in both cases you place the implant at the level of the bone in the area of the molar. So you can see in one side we don't make any bone reduction. So at the end we compromise the length of the clinical crown. Remember that by placing the implant deep enough from the margin of a plant crown, and deep enough means 3 millimeter from the margin of plant crown, you will obtain later the space for ideal pink and white aesthetic. That's the situation of the right side of the screen. Can you see the difference? And this is in the real case after I suture. Let me show some slides of this case. This is after the extraction using the thermoplastic stent. You can see where is the margin of this crown, and you can see where I reduce the bone. Can you see that the finishing line of the two and the central implants are very close to the level of the bone? This is because the implant is below the bone after suture and with the provisional. This is similar to the waxing that we showed to the patient. This is after osseointegration tissue heal around the provisional restoration. And this is the case in 2006, where I follow the sequence of determining what is incisal edge and occlusal plane, where is the margin, and later where is the bone, to place the implant by follow the 3A to B rule. And if we make a comparison between every year in a frontal view from 2006 to 2012, you can see that the soft tissue remains stable. And if you make a zoom, you can see that we don't have big change. Soft tissue remains stable. And in a lateral view, it's the same. Probably it looks better in 2012. Take a look between lateral and canine, or central and lateral. And very important that we can preserve the level of the bone. This is in 2006, and you can see that the level of the bone is at the level of the implant. And in 2012, can you see, remain stable. And here, remember that we made reduction in canine and first premolar. Can you see that the bone remains stable? Take a look of the interproximal bone between both central. Give the support for the interproximal papilla. Very important that patient can clean below this fixed partial denture to help in the preservation of the bone. And the most important from my point of view is the conical connection between abutment and implant, because we reduce this micro gap so we don't have any fluids around this area and we can preserve the level of the bone. So in conclusion of this short presentation, the first step in an implant restoration is the determination of the 3D position of the new prosthetic teeth. One single crown or a full mouth reconstruction. The 3D position of the teeth. Once you know what is the position of this crown or this crown, we will make the analysis between the distance of the margin of the crown and the existing bone in apical and lingual direction, looking to apply the 3A to B rule. And we can use the 3A to B rule as a diagnostic tool to plan in the case and also to place the implant, because the rule will show me if the bone is in a perfect position or maybe I have too much bone. In the majority of cases, bone will be far away, and it's an indication of a fixed detachable restoration where pink and white aesthetic will be incorporated into the prosthesis. And remember that the ideal depth of the implant will give the space for the biologic width and for the correct crown length. So before finish, I want to invite all the audience to our courses in the Mediterranean Prosthodontic Institute in Castellón. This is the material that a participant can take home. They receive a surgical and prosthetic kit for the workshops for maxilla and mandible, where we perform different techniques. They will receive a full color book with all presentation, the DVD with the PDF of the lectures, the DVD with the reference, also the DVD with the social activity picture, and we design our MPA certificate in a special frame. So if you have interest, this is my city, Castellón in Spain. If you want to know more about all our hands-on workshops in Castellón, or if you have interest in our DVD series that are around 1 or 1.5 hours with different techniques, different protocols, you can take a look of our web, prosthodontics.es. If you also want to know about all the models that we are using for our hands-on workshops, you can take a look to our company bondmodels.es. So with this, I finish my presentation, and I want to thank all of you for your kind attention, and I hope you can take some information that you can use and you can apply in your office in the benefit of our patient. Thank you very much.